And I've been very keenly interested in this field of DBS surgery now for past 20 years. Me, together with my neurologist colleagues, we have done more than 400 such procedures. I see Dr. Ravi now. Hi, Ravi.
Hello, good morning. Sorry if there was some technical hitch.
No problem.
It's all cleared now. Yeah. So as I was telling you, as Dr. Aditya Gupta was telling, we have planned this program. I think I'll probably introduce you, Aditya, and then we'll continue.
Sure.
So Dr. Aditya Gupta is extremely well-known functional neurosurgeon. He has one of the largest series of deep brain stimulation procedures done by him. He was initially additional professor at the All India Institute of Medical Sciences, after which he was associate director at the Vedanta, after which he is joined, at present he is the director of neurosurgery in Artemis Artemis Hospital in Gurgaon. So he is got a lot of achievements under his belt. It will be a big thing to list everything, but ever since he's been a student, he's been on the top, getting the best outgoing from AIIMS, and then subsequently a couple of awards, the Daru Bija Tata Award, then the Best Research Paper Award, etc., etc. He's got over 45 publications in index journals. He has 6 chapters in books, and he's got membership in all the most societies in neurosciences, listing some would be NSI, the Stereotaxy and Functional Neurosurgery Society, the Skull-Based Society, and the Asian Congress of Neurological Surgeons. His areas of interest are apart from functional neurosurgery, is brain tumor surgery and radiosurgery, epilepsy, aneurysm surgery, AVM surgery, and brachial plexus surgery. Dr. Aditya Gupta, welcome to this group, and we shall start with the sessions with your talk. Thank you.
Yeah, thanks, Ravi, for that very kind introduction. I will sort of make a quick 10-minute presentation. I don't know if my slides, you can see my slides. Can you see my slides?
Yes, I think we can see the slides.
Perfect. So again, a very warm welcome to all of you. And my attempt here would be to take you through some aspects of life after DBS. So for a patient who undergoes DBS surgery, the aim of this presentation is to tell you the nuts and bolts of what it may feel like and what it would be like to live after having had a DBS surgery. Now, because this is the first presentation, I will just show you 2 slides to introduce you to the topic of DBS. And basically what we do is we implant 2 electrodes in a deep part of the brain, typically the subthalamic nucleus. Now, many of the patients think of DBS as a very experimental kind of treatment, but I must assure you nothing is farther from the truth. If you look at this slide, work on this kind of treatment began many years ago. And to show you the next slide, the FDA from United States has provided approval for DBS for Parkinson disease now for well over 20 years. So DBS is something which should not be seen as an experimental or exploratory kind of a treatment. It is a very well-established treatment, and thousands and thousands of patients across the world have been able to get the benefit of this technology. Now, I want to show you how it is like to have a DBS surgery and how is the effect afterwards. So this is one of our recent patients, and if you look at him, many of you will relate to him because you see the kind of walking problem he's facing, and you just saw how his right hand was shaking. And his son is helping him with walking. And this is a video taken on the day of the DBS surgery. So for DBS surgery, we put this kind of a frame on, which you see the patient has on his head, and he's quite comfortable with it. Although to some of you, it will look a bit bizarre, or you may get taken aback by having to see this patient with a frame, but see that he's very pain-free and he's comfortable with it. And you can see the Parkinson disease symptoms so clearly with his right hand shaking and his shuffling way of walking, which probably many of you can relate to. And this is the same patient on the next day after surgery. And you can see the right hand tremor is gone. And he's speaking fluently. So we are making him do a backward counting. And you will see fine motor movements with the hands. He's easily able to wear his spectacles. He's keeping his hands at rest. There is no shaking of the hands. And he's wearing his slippers. And practically without any help, he is standing up, he has good balance, and he's taking steps and walking very, very easily. So this kind of a result is what we can expect after surgery. Now, the next thing which I want to tell you is that DBS enhances the quality of life. That is the main thing to understand. And it enhances the mobility. Now, you may ask me, how does a patient actually get enhanced quality of life? So basically, after DBS surgery, the stiffness is gone, the slowness is much better, the tremor is gone, and patients, some of you may be patients who are having dyskinesia. Dyskinesia, as you know, is a very, very socially embarrassing abnormal movements of the shoulders and the hands. So typically patients make dancing movements like this, or with their hands or with their feet. They have very peculiar movements which can be very socially embarrassing. So once the stiffness is gone, the speed of movement improves, the tremor is gone, and the dyskinesia is gone, the quality of life becomes very good. To show you another case, this is a lady came to us from Nepal, and she had what is called as a young onset Parkinson disease. So she started having Parkinson when she was 42 years old. Right now, when she came to us for surgery, she was 48 years old. The same situation. This is on the day of surgery with the stereotactic frame on. She's quite comfortable and pain-free. But look at the way she's walking. She is taking very, very small shuffling steps. Typically, before the operation, we stop the medicines 12 hours before that. So the last evening dose is what she received. So it's not surprised that she is stiff and she is having this particular kind of walking problem which you have in Parkinson disease. And to contrast, this is the same patient on the very next day after surgery. You can see the dressing and you can see how easily and independently she is able to walk. So of course, the rest of the details, surgery details, etc., Dr. Ravi will be discussing and showing us. What I would like to discuss with you in the next 5 minutes is the immediate post-operative precautions. So immediate post-operative, the most important thing to take care of the surgical wound. So as you noticed, there will be 3 wounds, 2 in the head where we make just a small hole in the bone, and 1 where we put the pacemaker. So there should be no handling, no itching, no scratching of the wounds at all. We should keep a close watch whether there is any redness or swelling of the area of the operation, or if the patient is having fever. And typically, if everything goes well, these stitches are removed anywhere between the 7th to the 9th day post-operative. So this is the immediate precaution, which is basically, if I can summarize it, it is care of the wound. Now, long-term precautions, many of the patients get apprehensive that after DBS surgery, their quality of life is going to get impacted, and we will be stopping them from what for them is a normal quality of life. So you should be reassured that there is hardly any restriction on activities. Taking a long distance flight, going into high altitudes, for those who are younger and very physically active, you want to do scuba diving, there is nothing against it. So DBS surgery does not impair the range of activities that you can do. At the same time, the simple long-term precautions are absolutely no handling or playing with the pacemaker, or no itching or scratching of any of the surgery areas. And keep a close observation. Sometimes infection, which is a very rare complication of DBS surgery, can even happen in a delayed fashion after several months. Now, the additional thing I would like to put your attention to is that just avoid overextension of the neck and extreme neck movements, because these extreme neck movements can put a strain on the electrodes which pass from your below the collarbone up to the head. So if you're doing very extreme neck movements, it can create a strain or even a fracture of the electrodes which have been placed. Now, because there is a pacemaker in place, one has to avoid situations in which there is a high electromagnetic or RF field. Now, typical precautions are high powered tools, arc welders, surgical diathermy machines, MRI equipment, and basically metal detectors which you have in shopping malls and in the airports. These are all devices which can generate electromagnetic field, and therefore one has to be precautious while being near these kind of equipment. For example, if you have to go through the airport or the shopping mall, you should state you have a pacemaker in situ, and the security agencies have a separate pathway for patients who have a pacemaker. Now, example of products that generate high RF energy are automatic garage door openers, ham or CB radios. Thankfully, we don't use many of them in India. And if you're very close to a radio transmitting tower, and again, surgical diathermy and television dish systems. So these are all devices and appliances which have a high RF energy associated with them, and these one needs to take care. So bottom line, how do we get a good outcome from DBS surgery? The things which Dr. Ravi would be discussing with you are that it is always about the surgery has to be on the correct, carefully selected patient at the correct time, and for sure that the moment you start having fluctuations in medical treatment or you start having dyskinesia, that is the correct time to go for DBS surgery, not stretch yourself to the very last stage. And then when you have a lot of secondary complications of Parkinson disease, at that time you decide to get surgery. It has to be by a team which is experienced. And by experienced team, what I would say is, let's say a team which is at least doing one procedure every month. So that should be the basic criteria of choosing a surgeon or a team. And of course, a well-performed surgery is the one of the main things about how to get a good outcome. But post-operatively, managing the medicines, managing the pacemaker, physiotherapy parts, some of the patients may need psychological counseling and so on. So all these things create a good outcome after DBS surgery. So this is what I was telling you about the appropriate team. And to summarize my talk, what I would like to say is that in this day and age, we have to understand that DBS surgery is a very, very well established procedure, and a good team with a good experience, good surgery, good teamwork, and properly selected patients. These are the essential ingredients what give us a good outcome after surgery. After DBS surgery, you can practically enjoy a normal quality of life without any restrictions, save for the few precautions which I have listed. Thank you.
Thank you, Dr. Aditya. Thank you so much for the talk. It was really gave a lot of information. Should we continue with the talks or then go ahead
Uh,
with the
yeah,
next?
so I think let's see if there are any questions. Do we have some questions for the talk? So while we start getting the questions, I would like to introduce my colleague, Dr. Ravi Verma, who will giving you the next talk. And Dr. Ravi Gopal Verma is a very, very well-known functional neurosurgeon practicing out of the Aster Hospital in Bangalore. And he has been having a wide experience of surgery for movement disorders, epilepsy, and pain, apart from holding several academic positions in institutions like the MS Ramaiah Medical College. He started the DBS program for treatment of Parkinson disease at NIMS and also at KEM Hospital. And he has a wide experience of DBS surgery. He has received numerous awards and he has been invited as a guest faculty at numerous forums, national and international. And he has basically gained experience in DBS even for the more rarer indications. So with this, I'd like to welcome Dr. Ravi Verma to give his talk.
Yeah.
If I can just answer one question, I think
Sure. Please.
in the meantime. So there is a patient. I think we can sort of answer it together. Now the question is, the patient is the lady who's asking the question. She's saying our patient is my mother, and she has Parkinson for almost 15 years. She has very low movement. She is on tube feeding. She's 73 years old and on total nursing care. So can she be a candidate for DBS? Now, of course, I would like to hear Dr. Ravi's opinion on this, but my take is that in general, I avoid taking up patients for surgery who are older than 70 years. The exceptions would be if I see a patient and she looks to be very, very healthy otherwise, and she does not have too many other diseases like diabetes, blood pressure, heart disease, and so on, then we could offer DBS surgery on a case-to-case basis. What I'm also hearing is that 15 years have passed. So practically speaking, if it was not Parkinson disease, by this time it would have become very clear to us. At the same time, she seems to be not having a very good function, motor function, and she can has limited feeding also. So I would say I would like to have her seen physically, how frail she is, how fit she is. I would also like my neurology colleague to confirm the diagnosis. And based on the evaluation only, then I could say whether we could take up this patient for surgery or not. So Ravi, your views on this?
Yeah, I think it's exactly the same, but I would also involve the anesthetist to get the anesthetic
Yes.
uses and combination.
Yes.
But apart from that, I think I would follow whatever you just
Right.
highlighted.
So I think the last question before your talk
Yeah.
is that there is a patient with DBS surgery done in 2017, and she is not able to walk or get up from the chair. What should be done for this kind of a patient? So Ravi, would you like to answer that?
I think first of all, we'll have to find out the placement of the electrodes. I think that's very important in this
Right.
patient. So if the post-op scan has been done and the placement is right, then we'll have to think about programming and how the programming has been done, because there are so many permutations and combinations which help in different aspects of Parkinson's disease. For example, if there's rigidity, difficulty in walking, the frequency can be altered. And if there is freezing, if you have a lower frequency, it has a better effect. So I think basically the patient has to be evaluated in between with the neurologist and the neurosurgeon, and they should sit together and say, okay, if the placement is right, if the surgically the circuit is present and doing functioning well, the electrodes are good, the impedances of the electrodes are good, and placement is good, then it comes to programming. If there is a fault in any of these mentioned surgically, then those have to be corrected before we take it further. Once we confirm that the surgical placement and everything is okay, then it's a permutation and combination of multiple sequences in programming. And with the newer battery and the newer modalities, we can have 2 to 3 modalities of stimulation, where one can be when the patient is asleep, one can be when the patient is very active, and one can be when the patient wants to walk more than talk, because sometimes when you make the patient walk well, the speech might come down. If this patient is able to speak well, but rigidity or other symptoms may come back. So I think it's a constant pursuit with permutation and combination, sweet spot, after which one can say that one will be able to get a very good outcome, and then we should follow that. So I think basically the patient needs evaluation.
Right. So I would totally agree with that. It's too difficult a question to give a straight answer. So apart from what Dr. Ravi mentioned, that, checking the electrodes and then going to the programming, some of the patients need a lot of intensive physiotherapy. A lot of the patients may need intensive speech therapy. Some patients may have mood problems, because of which they don't have the motivation to get up and do the activities. So it's a very complex question to answer offhand, but it needs an evaluation by a good team of specialists to zero down on what is the reason for that. So perfect. So Ravi, I request you to proceed with your talk.
So the talk is on screen. I hope all can see the screen.
I must apologize. I have to leave for the hospital at 11:45 or so. So I may leave midway.
That's perfectly okay. No issues. So I hope the screen is visible to everyone.
Yes, your screen is visible. Yeah.
So okay, as just to for the people who do not really know exactly what Parkinson's is, which I'm sure in our group now will not be there, but this is the approximate picture of what Parkinson's disease features are. The blank facial expression, stooping forward, slow, monotonous, slurred speech, reduced arm swing, rigidity and tremor in the extremities, and short shuffling gait. Now, these are the red flags with which we consider whether the disease is Parkinson's, and then evaluation from that point. The most important thing, Parkinson's disease and its treatment involves a multidisciplinary team. And if they have all experienced in movement disorder and in Parkinson's disease, the team becomes much stronger and more robust. So the main 3 people involved from the surgical point of from the medical point of view is the neurologist, the neuropsychiatrist, and the neurosurgeon. The neurologist, basically, most patients go to neurologists with Parkinson's disease, and there are varieties of types of Parkinson's disease. Most amenable for DBS would be the idiopathic Parkinson's disease, and they've got some features with which the neurologist needs to differentiate the group of patients that can benefit from DBS and the group which DBS wouldn't really help. So that is where the neurologist comes into play. Once the neurologist examines and sort of identifies a patient for Parkinson's disease, then he takes the help of a neuropsychiatrist or a neuropsychologist to get the patient, 1, mentally prepared, 2, many of these drugs can have antipsychotic issues which have to be dealt with and which have to be, because a very prepared patient would have a better outcome than an unprepared patient. And when I say prepared patient, it is in all domains, in the neurological domain, in the psychological domain, and the mindset of the patient, and the acceptance that this is going to be a surgery, and the surgery has to be, it has to be faced. All these things are very important. As I told you, again, certain drugs cause reactions. The drug optimization is important. So the patient's mental health is extremely important. After which the patient is referred to the neurosurgeon for the appropriate procedures. And The neurosurgeon then again evaluates. Now, most neurosurgeons who are functional neurosurgeons are a neurologist also. So we really have to look into this point of view from the neurologist point of view, and then we take consideration from the neurosurgeon point of view. So many times we all know that when 2-3 minds work, we are able to find out something better, something which is more appropriate, etc., etc. So when a neurosurgeon finds a small point saying that, okay, maybe in your when you're totally on and you get freezing, that is something that may not improve. So that has to be told, and then analysis of freezing and whether it is on freezing, off freezing has to be again, probably would refer back to the neurologist saying that maybe these are the reasons why we may not agree for surgery, or it would surgery help. So there's a discussion between the neurosurgeon and the neurologist. Sometimes if you look at what the patient wants and what you can give, there is a disparity. You cannot get a near normal person, because sometimes the need or the want of the patient is much more than what we can give. So in that situation, we need to get what the patient requires and needs and say, okay, if he says this off and during on, I still have freezing and I want it to go, that's a red flag. We need to warn them that may not happen. But anyway, there is a slight possibility that it can. So it's basically an interaction between the neurologist, neurosurgeon, and neuropsychiatrist. Now, once the surgery is over, even pre-op, that is pre-surgery, there are some important involvements with the physiotherapist. The physiotherapists need to analyze what are the issues with the patient. The occupational therapist is involved, speech therapists are involved. So all these people are involved prior to surgery, during surgery, and post-op. So, and treatment, these people need to be there. And we involve all these people even in the pre-op, so that when they come on the post-op phase, they each one will know what are the things that are important. Where is the speech an issue pre-operatively? Has it improved post-operatively? Can we do things about it? Can we improve many of these drugs produce psychological problems. Can that be taken care of post-op, medication-wise? Because we always, as surgeons, want the patient to be much better off than pre-op. That is any neurosurgeon's wish, that they should be better off. So when we keep that in mind and the needs of the patient in mind, then a multidisciplinary action would really help in analyzing the right patient and giving the patient the right modality of treatment. Now, this is a small video of how we analyze pre-op. So without any medication, as the patient is off, is the first video that you can see. You can see the movement is a little less. You can see the mass feces. You can see a little stooped posturing. And then you can see the way he walks with those little shuffling gaits. Now, this is pre-medication. Now, to analyze this patient, we give a double dose of Syndopa, which is called a Syndopa challenge test, done by the neurologist, and they assess the score. Now, this is the post-Syndopa. So you can see much better. The arm swing is much better. The face is, the masked face is much better. You can see how fast he is walking. So this is what we achieve. We want to achieve by surgery too. So because one thing that has to be remembered is what we get post-op will be his best on. We can't get better than his best on. So that is why that should be what realistically the patient should expect from a surgery. That is, if the on is very good, we will replicate the on. Now coming to the role of neurosurgeons, what we do as neurosurgeons, it's nice to understand, though we have ourselves not really purely understood what the reason of why DBS helps is, but the postulate is that high frequency electrical stimulation mimics the effect of lesioning, and then that would help in alleviating the symptoms of Parkinson's disease. The advantages of DBS, of course, is there's no lesion created as such, just mimics a lesion. It can be done bilaterally. In a lesioning, when you do bilaterally, you have a lot of issues. Stimulation can be adjusted to improve the efficacy. And if you think there is something going to come up new, we can even stop the machine off, and then he'll be back to square one. Therefore, it does not preclude future therapies, and it's reversible. It's no permanent damage is created. Only a disadvantage probably is the cost factor, but then when technology comes with a little cost, and we have to take that into consideration, there is a very, very little surgical risk, about 2.0 to 2% of surgical risks, which include hemorrhaging into the brain, and placement of the electrode in the wrong place, or not getting the desired benefits. But those all together constitute only 2%, and we need to think of the 98% of benefit that you can expect. And one big question that everyone asks: if we are spending so much money, do you think it is we can cure Parkinson's? No, it is not a curative surgery. But looking at it from a different point of view, when you say cure, we alleviate symptoms, and that is cure. The progression of Parkinson's does happen, but it is delayed. And there are new papers coming out, new research things coming out, that with DBS, the progression of Parkinson's, which normally would happen, is slowed down. And one. And number two, if you have symptoms free at that period, it's more or less like cure. But Parkinson does not go away. It progresses, and it's a progressive disorder, but the quality of life, which is very, very important, that is what improves. So the remaining life with Parkinson's, for example, if you're diagnosed Parkinson's at 60, up to 80, you have to, the Parkinson's is going to progress. And it can progress very rapidly and get you out of society, get you as secluded into confinement, etc., because of social reasons much earlier. And DBS pushes it and lets you get social and get to near normal life for a very long time. And that is what has made DBS in Parkinson's disease a very much sought after modality of treatment, and also relatively safe modality of treatment. And we have seen the outcome being very good, and the FDA had approved this from the American point of view long back, because they have known the efficacy of subthalamic nucleus TBS. Now, this is a small video giving you an animated procedure, or animated picture of the procedure, where two small holes are made within the skull, and the electrodes are put deep inside the brain into a nucleus called subthalamic nucleus. And from the nucleus, the wires are extended from your neck and down onto your chest, where your battery and the battery is placed. So everything of these are subcutaneous, and one cannot see it outside. And people who have already had DBS will vouch for the fact that when you walk out, and nobody knows that you have DBS. You have such a big implant kept into your body. So it's very important, social stigma and things like that. But it really is something that is concealed. So what are the predictors of outcome? Now, we always look for good outcome. Now, you do something badly, the outcome is not good. You do it in a place where they do not have experience. There are many centers which have one-off DBSs. As Dr. Aditya Gupta had told, please refrain from going to such places, because you need to go to places which are used to doing DBS. And as Dr. Aditya said, 1 or 2 a month, if the centers are doing, those are centers that you need to go to. Because if the outcome, if it is wrongly done, then the effect is lost completely. And there are so many steps in doing DBS that even one step is missed, then you get it in the wrong place. And putting in a 15 lakh equipment and getting it in the wrong place is not very nice. So therefore, it's very, very important where you select to do your surgery, you see whether the team exists. There should be a good neurologist, neurosurgeon combination. There should be excellent facilities which even intraoperatively will confirm whether the lead is in the right position, so that we don't have to redo it or pull it out or push it out. And we have a good neurophysiology team, which will then the OT looks after every aspect of the surgery, which I'll be telling you in detail. So it's very, very important where to select. Coming to the other factors, the patient-related factors, age, because the quality of life and the quality of the person at 86, if he's running around and he's absolutely fine, he deserves this therapy. But otherwise, we would say 80 would be the age. As young as 13-year-old, 12-year-old DBSs have been done for patients with Parkinson's, which starts much earlier in life. Men are more, if you look at the statistical outcome, men do better than women. We don't know why, but then there is some study done there. Duration of the disease, as Dr. Aditya again different, we cannot put in a DBS very late, because when your on period becomes very less than 2 hours, less than 1 hour, then it is detrimental to put in a DBS, because you can cause problems, and you can get other side effects of the disease, which would make us think twice before putting a DBS. So post 5 years, if you are indicated and if you are diagnosed as a person who requires Parkinson's disease, get it done. Anytime after 5 years, and the best judge would, of course, be the neurologist, neurosurgeons. So take a suggestion from them, but the moment they decide that you are a person who would benefit from DBS, go ahead for surgery. Then a type of surgery, always bilateral in Parkinson's disease, because disease is bilateral. So even if you get one side, something called hemi-Parkinson's, it is inevitably going to be bilateral. So it's always better to get bilateral thing done at the same sitting. Patient selection, as I told you, these are simple terminologies. Anyone responsive to L-DOPA, where the rigidity, tremor, freezing improve with SIM-DOPA, you are a good candidate. When a person gets dose-limiting side effects, now when SIM-DOPA helps you, but then when the disease progresses and you need to increase your SIM-DOPA, at that point you get dyskinesia, which is a side effect of SIM-DOPA, of medication, which would again cause a problem, because the dyskinesia can be more bothersome than a small tremor or a rigidity. So dyskinesias, dose-limiting dyskinesias is another very good indication. And people who, if he is good in his on period and he is socially much more active, DBS is for him, because quality of life improves and the person has to undergo DBS as soon as he has been identified as a good candidate. Candidates that does not benefit, there are benefit, large number of Parkinson's-like syndromes which does not benefit. Such people, it has to be very clearly differentiated by a movement disorder specialist and neurosurgeon to find out whether she's an appropriate candidate. Because a wrong candidate can again give disrepute to the deep brain stimulation itself. Now, surgical steps quickly. One is the frame fixation, as you can see right there. It's a metal frame, that it's a titanium frame that goes onto your head. And this is important because we need to access a point in the middle of a sphere. So we need to calculate the X, Y, and Z coordinates to find out what is the center of a point. So we put the brain into a stereotactic realm, and through that we define where the nucleus is by looking at an MRI, and from that, using a X, Y, and Z coordinate, we reach the point. And once we reach the point, we know that's the nucleus. From above, we pass the electrode right there to go and fall at the nucleus. We stimulate the nucleus. So once we put this frame, take a CT scan, merge it with your MRI, we will get this stereotactic realm where we know exactly where to park the electrodes. And then we park the electrodes. And when we park the electrodes, two things we experience. One, the physiological effect. That is, each of these nuclei have got a particular language, which we pick up using microelectrode recording. We record these small languages, and then we realize it's like getting down from probably Delhi to maybe Bangalore. you have multiple languages, and when you reach Karnataka, you know Kannada, and when you reach Bangalore, that particular dialect is very specific. Similarly, in the brain, from top to bottom, there are different languages, different nuclei have different languages, and as you reach to the subthalamic nucleus, you know you're at the right spot. Now, once you're in the right spot, you need to reconfirm whether we are in the right spot. So we stimulate. We stimulate to see the good effects. So intraoperatively, the patient becomes rigid free, becomes tremor free. Then we know we are in the right spot and we place the electrode there. Post placing the electrode, we confirm intraoperatively, we confirm that the position is as we planned and in the same spot as we wanted it to be before we put in the battery. And after that, we do the programming. And the programming is done by the neurologist with adjustment of medications. So another thing that the patients are required to know is once you do a DBS, we don't stop medications the next day. We slowly, it's like a relay. We hand over and take over. That means the drugs hand over to DBS and the DBS takes over. So there can be a point where there are a few patients, percentage of patients who we have stopped the drug completely and the stimulation has taken over fully. We have some patients who have reduced the drug by more than 50, 60%, 70%, and stimulation takes over the rest. The best thing is the on that you enjoy intermittently with medication, you will enjoy continuously with stimulation. And that is where the difference between quality medical treatment and DBS is. There's a new paper that has come out, new research that has come out that if you look at the long-term effect of patients with only medication and with DBS and medication, you see that the prolonged, the delay in Parkinson's becoming worse is much better with a DBS group, where the quality of life is better, the progression of disease is better, and the medication sensitivity to medication also becomes better. So we'll just show you a small video of a surgery that we had done. This was done in 2008, 2010 in MS Ramaiah Medical College. This was the first DBS which was live shown all over, and we had people all over India and international there in this program. And you can see, I'll just quickly go through people who cannot see blood. So this is the assessment that we do pre-op. Then, after that we place, this is how we place the frame. This is how we place the frame here. After the frame, the CT scan is done. This is the operation theater. This is how the patient is kept on, made comfortable. He is conscious throughout. So it's very, very important that the patient cooperates with that. He sleeps very well the previous night, because throughout the surgery, we're going to communicate with him, and we need to know that he is improving. This is Dr. Andrew Parent, who I trained with in Canada, who had come down for this workshop. And you can see the patient has no pain. He's feeling no pain because we have given local anesthesia all over while. And you can see his face as we are doing the whole, which we call the brain. He is fully conscious. He has no pain. So that is very important. He will not, or the patient will not have pain. And then what we do is, once we put in the electrodes, these are the electrodes that are seen. Very fine electrodes, multiple electrodes are put into the brain, 5 to be precise, sometimes 3 to 5. And why we do that is because it's so precise, it's just 6 into 2 mm nucleus. So we need to be very precise in placing. So we put 3 to 5 electrodes up front, decide which is the best of the 5, and then replace it with a permanent electrode. So that is how you can see the tremor, and the tremor is there. Now we're going to stimulate. Once we stimulate, we'll see the tremor slowly disappearing. And you can see this is our neurologist who keeps checking, because the neurologist also is in the operation theater. You can even get one of your family members to sit with you while the surgery is going on and communicate with them, so that they are comfortable, the patient is comfortable. So this sort of examination, which he would do otherwise in the OPD, is constantly done in the operation theater too, so as to get the exact benefit of deep brain stimulation. Now, if you see, the patient's tremor is definitely better. So now we are going to stimulate a little and see. You can see there's still some tremor, and at this point, the tremor is totally gone. We check his speech at that point. We check his other activities. We check his sensorium. And if everything is fine, we feel that that is the right spot. And we would then put the final electrode. This is the placement of the final electrode, as you can see. We mark out what the final electrode looks like. And this is what the final electrode looks like. which has got 4 contacts. And each of these contacts, at least 2 of them would be within the subthalamic nucleus and the appropriate site in the subthalamic nucleus, which is to the tune of 2 to 6 mm. So this is the final placement of the electrode. And you can see once the electrode is placed, we take a confirmatory radiography. This is how the wound is closed. And after that, we do it on the other side. And once we confirm, this is the place where we would place the chest. All this is done under the skin. And finally, the battery is placed. That's the battery there, which is coming in, which will be placed in the pocket. And everything is clean and closed by the end of the surgery. And at the end of the surgery, you can see that he's fine. Now, certain things are important. Once we do the surgery, patients have some expectations. And then they say, no, actually, I'm not really good. I could be better. Then we switch it off because we can show that it is reversible. So this person is a patient who's been with us for a long time, an excellent individual. He has shown this video and given us permission to show this video. Very nice gentleman called Peter. He comes once in a while and says, no, I'm not happy. So we switch it off. We switch it off at that point and tell him if this DBS was not there, what his status would be. And that would convince him that, okay, my God, this is really doing wonders. You can see the video here. In this video itself, we are just switching off. Once we switch it off, this is a remote control that we use to switch off. You can see we keep it on top of the battery, which is there below the skin. You can see the wires. You can see that he's not even, doesn't even look like a patient who's got operated for DBS. But once we switch it off, you can see first the facial changes. Just see his facial changes. Then just see his hand movements. They're all slow, as any Parkinson's would have experienced this. And you can see as we have switched it off, the tremor is slowly coming in. We are asking him to walk. He's not able to walk. And you can see that there is this tremor which is coming up. You can see that tremor in his hand because he was more of a rigidity dominant than tremor dominant. But you can see that the subtle tremor. He's not able to walk. At this point, we told him, okay, we've switched it off. If you think it's not working, you can go home. But he cannot go. He's stuck there. And so we switched it on because he says he can't move one step ahead because he's frozen in time. So we switch this video on, and you can see once we switch it on, what the reaction would be. Please note that the tremor has stopped, and you can see his mobility has come back, and he's extremely happy. Now, this sort of a reaction is what we get when we switch off and switch on. And therefore, it's very important to know that you cannot be near normal, but you can't be so normal that you are like without Parkinson's, but you're definitely much better. And he realizes that, and he is another person who had very dominant, predominant tremors. And you can see here, we switch it off, and when you switch it off, you can see how his tremor starts. Just imagine this is what his tremor was without the DBS. Now we're switching it on, right? You can see us switching it on right there. We're switching on the battery. This is a tremor dominant Parkinson's disease, and the tremor just stops as if nothing ever happened. All this good outcome is only when you select the patient right, when evaluation is done perfectly well. So I think we would end with this. I would conclude by saying, because we keep a lot of time for question answers, I think most important thing for a good outcome is the right patient selection. I would underline that 2 to 3 times because that's the most important thing. Accurate imaging, right target selection, precision. That is also extremely important. Again, double line under that, precise placement of the electrodes, and then the right programming. So thank you. I hope this covers most of the questions. Any questions that you need, please feel free to ask us. Where are the questions? Okay. Oh, any more?
That's also answered how you want. So you can answer.
No, this is answered. Last year, remember, she sent it already. We discussed it. It was answered. I think most questions here have been answered. If there are any more questions, we would wait for some time. Any questions? Um, so, Pusara Lakshmi, I think we had answered this question. So, what would ideally be is it would be good if you could bring the patient to one of our centers. I'm in Bangalore, and Dr. Aditya Gupta is in Delhi. If you could bring the patient to one of our centers, we can reevaluate and check up whether where the issue lies, whether it's the in placement of the electrodes, or is it in the programming part, or does it just require some amount of rehabilitation. So we would be able to assess this with our team and then give you an answer for this.
You can conclude, sir.
So I think we can conclude. I can send you my email address where we can keep in touch. You can send me queries in my email, and then we can work on that um, as and when required. Okay, I think we can conclude. Thank you for. Huh?